And hello, everybody. I'm Catlin Morgan, Education Manager for Institute on Aging. Welcome to this program, which is presented by the Citywide Clinical Consultation Services Group, and two of the members of that are with us today. Our primary presenter, Ashley Mooney, MS, LCSW, is a clinical consultant for the Citywide Clinical Consultation Services of IOA. She has focused her clinical social work career on adults with multiple complex problems, including homelessness, substance abuse, acute and chronic medical conditions, histories of incarceration, trauma, and undertreated psychiatric challenges. She served as both clinician and supervisor in permanent supportive housing and residential psychiatric facilities. Some of her previous roles include clinical social worker with UCSF Department of Psychiatry at the Renee Casanave apartment.
Casanave, yeah.
Oh, perfect. Thank you. I should have asked before.
RCA for sure.
Okay. Resident Services Manager 2 with Mercy Housing and Program Director of Progress Foundation's Clay Street House, which is the largest unlocked transitional residential psychiatric facility in San Francisco. Ashley holds a master's in biomedical science from Tufts University and earned her master's in social work from the University of Southern California. And with Ashley by her side today is her supervisor, Ann Almendral, LCSW, clinical supervisor and consultant for the Citywide Clinical Consultation Services Group. And Ann has worked in both the public and private sectors, serving in community health settings and as an inpatient social worker. Some of her past roles include faculty member and social worker at Langley Porter Psychiatric Institute, University of California, San Francisco, program director at St. Mary's Hospital in San Francisco, clinical administrator at United Healthcare, and social worker at Asian Community Mental Health Services, and earned her MSW, LCSW from San Francisco State University. And without further ado, I'd like to turn it over to Ashley and Ann. Ann, would you like to make an introduction yourself? I'm going to become a disembodied voice now.
Well, not before the compliment from my Michelle saying that you have quite a golden voice, which is true. Thank you. Yeah, so I'm Ann Almendral, along with Ashley Mooney and Rebecca Hunt, make up the clinical consultation group at IOA. We provide consultations to the community-based case managers all over the city, as well as partner with the Department of Aging and Adult Services, who funds our program. We also do community trainings such as this one, where we invite all of your participation. And we also are in a position now of providing multidisciplinary team trainings for more agency-based needs, such as behavioral de-escalation, mental health, trauma, language, and things such as that. And lately, I think Ashley and I did an anti-Asian hate training with self-help for the elderly. But welcome. Without further ado, I think Ashley will provide for you a well thought out approach in terms of partnering with the system of care of the medical world, where we're seeing more and more of our clients experience complex medical issues as a result. Part of it is pandemic, part of it is economics and the aging process. But without further ado, take it away.
Okay. All right, folks, you should be able to see a slide with some lovely balanced rocks, indicating that you guys are still seeing my slides. Is that right?
Mm-hmm.
Right.
Okay, fantastic. Great. Always good to make sure we're oriented to what we're up to. All right, guys. Hi, I'm Ashley. I am a pretty fast talker. I will do my very best to not kind of run away with us. But welcome to Medical Harm Reduction, and this is part 2. So the medical harm reduction training we did last just a few weeks ago with Becca and myself, and this comes as the end of our harm reduction series. We started with behavioral health, focusing on mental health and substance use, and then our next harm reduction training was around housing and housing retention. And this final one is around medicine and medical conditions. And this specific training is going to cover more of how to have conversations with your client around their wellness and their health. And introduce us a little bit. ago, but this is the Citywide Clinical Collaborative. So, and myself and Becca, and we are a joint case management project of the Department of Disability and Aging Services and IOA. So we provide clinical consultation and training services to community-based DOS-funded case management and ADRC teams. And we've been here since 2007. So we're all licensed clinicians, and we do, like Ann said, group consultations, one-on-one consultations, quality assurance, and community training. So we're really happy that you guys are here with us today. So here's, excuse me, the overall kind of objectives for the training today, which is we're going to review theories and concepts that are relevant to harm reduction, specifically in health. And then we will, we're not going to learn basic medical care and follow-up because we did that in the last training, but that'll be something that we will touch on briefly. And then I think the kind of meat and potatoes of the training today is going to be counseling techniques around health and wellness. And finally, depending on time, we will discuss the kind of San Francisco medical resources and community-based health management services. Yeah, I like animals, and I kind of like little things that ground us in kind of time and place. So here's our kind of general outline for today. So we'll first talk about knowing the theories, right? The theories and concepts relative to harm reduction. Then we'll think about knowing your client and making assessments around the health skills that your client has or needs. And then we're going to kind of bring it all together to support your client's ongoing wellness with the community resources and kind of levels of care. So this should be a familiar slide for folks that have joined us with the other harm reduction trainings. So in our past trainings on harm reduction, we expanded the definition of harm reduction from kind of the initial concept, which was overdose and HIV STI transmission. That was how we reduced harm, is prevent people from getting HIV, getting STIs, or preventing overdose. And then we kind of said, all right, what if harm can be in more forms than just that? So we looked at mental health decompensations as a form of harm. Being more symptomatic can cause people lots of problems. And having behavior issues can cause problems in housing. And so this is kind of our broader way of looking at problems in our clients. So harm reduction becomes more of a lens that we look through than a specific tool we use with just kind of one aspect of people's lives. And so we interpret harm as grave disability or hospitalization, homelessness, incarceration, death, decrease in functioning. And then I think these other kind of more intangible things like a loss of family and friends or loss of access and loss of services. All right, so here are a big old list of kind of theories and concepts that I think are important for us to carry through when we're thinking about medical care and health and the clients that we serve. So motivational interviewing will focus on a lot and the stages of change. And we'll do that in detail, so I won't go over it here. But other things when we think about medical care and medical conditions is people's self-determination, right? In our kind of helping relationship, we want to be offering the client as much power and control over the decisions that impact themselves as possible. And autonomy folds into that. And I think sometimes when we're working with people that have multiple problems, sometimes it can be helpful to decrease our burnout by focusing on, okay, how am I empowering my client? How am I offering my client the opportunity to make their own decisions versus me, the provider, telling the client what they should do or what I think is best? You know, how am I empowering the client to use their own agency? And I suppose I've seamlessly gone into empowerment, right? I think a lot of medicine and medical care can be kind of top down, and we want to empower our clients to be their own advocate, and you know, our advocacy with them can be empowering, and that's another thing we want to really be thinking about in kind of our conversations. And with that, we want to hold compassion, right? Our folks deal with lots of problems. They have a lot of burdens and trauma, and we want to be consistently trying to put ourselves in our clients' shoes, and offering that compassion for all that they might be going through, because that is generally what we consider to be a large part of why people make decisions that either help them be healthy or make them struggle with health issues. And then we also want to be trauma informed when we're having conversations about people's health with them. And so ways to be trauma informed, there are plenty of trainings all about it, but the two major things I think are being authenticity, and being consistent. So you want people to feel like they can trust you as a provider, and being authentic and being consistent in the way that you're dealing with them can help. And then cultural humility, which is the idea that if someone is in a different cultural background than you, humility is not competence. So cultural competence is like, I know your culture and I assume that I know everything about your culture. Cultural humility says, I'm going to reflect on what I know and what I don't know and ask, right? So we're being consistently curious about someone's culture and how their cultural ideas and beliefs might come to bear, specifically around medicine. And with that is language. We want to make sure we're offering people care and support in a language that they understand, in a language that they feel confident in. Because if you can't communicate, or if clients don't feel like they can communicate, it's going to be really hard for them to use their voice in the most effective way. And then we've got disparity, right? There's people who have access to things and people who don't, people who have resources and people who don't. And there's a lot of, I think a lot can be said about that, but it's something we need to think about, because whether or not someone accesses care has a lot to do with whether or not they can. And there's a lot of reasons people would be able to or not able to. And we have to think about that as well when we're trying to support people to be healthy. And then fear and power plays into this too. The medical world has a lot of authority. The white coat syndrome, I think we talked about in one of the other trainings. There's a power dynamic in medical decisions, in medical interactions. And I think can be also a lot of fear associated with that. And we want to make sure that we don't forget that when we're talking to people about engaging with medical staff, engaging with being hospitalized, engaging with kind of anyone in the medical environment. So broad strokes, these are the theories and concepts we kind of want to use as we continue thinking about medical care. All right, so want a little chat action. So if you guys could tell us who's in the room. So, who you are, what agency you're from. It'd be great to just kind of get a handle on who our audience is today, and a little bit about what your definition of success is, kind of regarding medical or physical health. And Anne and Catlin, if you could help me out with who's showing up today.
Okay. So we have Joshua, resident case manager for Open House. Welcome.
Hi, Open House.
Caregiver, Paul.
Hi.
Welcome. Bridget, case manager for Out of Jewish Community Family Service. Paula, Liv, IHSS, supervisor. Welcome, everybody. The team from Bayview also.
Hi, guys.
Hi, Cesar. ¿Cómo está? Manager from IOA. And then we have somebody Michelle Selman Fisher, counselor for the intern for the Housing Works. Eli Neville, case manager also at Open House. Welcome. Healy, yes, from Kimochi. Welcome.
All right, beautiful. Well, thank you guys. It's awesome to hear who's in the room. More people will tell us who they are, and I welcome all of you.
Oh, yeah, sorry. Here's a success from Esther K to all the panelists. Success is equal to healthy, happy, and what was the other? And then greetings from Contra Costa County.
And productive.
And productive, yeah.
Wonderful.
And then care navigator for open house, Joe. Hello. Success is balance. Sure. Okay, cool.
Awesome. Yeah, so I think success is defined by the client and not us. You know, it might mean avoiding long inpatient or long ICU stays, or it might mean curing or preventing disease. I think success may also be simply empowering people to learn about their bodies and how to care for them, really at even a very basic level. And I think success may also mean full autonomy, right? The ability to die with dignity, or the ability to feel control over one's body, even if that means refusing or rejecting care. And I think that's where the compassion and kind of our self-care as providers come in, especially when people refuse care that we know could help. And success might mean an increase in people's safety, their security, and their stability, if only for a brief minute. That's kind of why we're talking about harm reduction here. And I think that's kind of what harm reduction is finding what aspects of a situation you and your client can change together and trying to make it happen. All right, thanks guys. Always great to hear familiar faces, and exciting to hear about folks from all over. Okay, so a lot of this is going to be review, so I'm going to speed up a little bit because I imagine we might have some discussion later. But the skills of kind of harm reduction, it's like medical for this one, but they've all been the same for the harm reduction. One is to make an assessment, right? Assess your client's capability, their capacity, the specific challenges they have, and the needs that they have. And then connecting them with the resources that are most relevant for them. And then support, finding ways to support their kind of ongoing stability. And then this is also review, so I'll kind of breeze past. But this essentially, if you were going to walk through all of these things, you take a look at all of the symptoms your client has, if you're aware kind of what symptoms are, or their behavior, specific challenges and risks that relate to those, and then the needs that they have and the strengths that they have. I think strengths is a big one that we can look at. And then the list on the right is a list of independent living skills. So coupled with kind of the deficit, kind of more medically based, you know, diagnostic based, you know, your client has this specific problem. We also want to look at the skills that they have. And these are a list of all the independent living skills. And this is mostly meant to indicate this next part, and that the problems that your clients have, so whether it's behavioral health, whether it's a medical issue, they all impact the client's ability to participate in their day. And they all relate to each other. And symptoms impact functioning. And I think when we're thinking about medical conditions and people's medical care, that can mean lots of things. It can mean people's hygiene. It can mean people's medication adherence. It can mean whether or not people eat or not. And then can mean what they eat changes, right? I've got little fancy avocado toast, and then I've also got cupcakes, right? So depending on how people are, if they're feeling well or not, if they're symptomatic or not, it impacts whether or not they're able to take steps to be their most healthy. And then these were the major medical issues that we went over: wounds care, hypertension, high cholesterol, diabetes, falls, kidney disease, cancer, cognitive impairments, and dementia. So there are obviously lots more medical conditions, but I think these were the ones that Clinical Collaborative saw as being the most prevalent, the most common among our clients. And so the general follow-up care for all of these is the annual physical, unless your doctor says more than that. Becca's not here with us today, or else she would give us a rundown. But I think overall, annual physical is kind of the follow-up, unless the doctor increases that or a specialist is involved. Okay, this is the last one before we will take a little break, and we can have a discussion if people have questions. But these are kind of the health skills, right? We covered the list of independent living skills. These are kind of health skills. So your diet, your exercise, your sleep, medications you take or not, and your dental health, medical care. So that's engaging with medical providers or not. That is being able to talk to medical providers. That is being aware of your own medical symptoms, conditions, taking care of your vision and hearing, and then sexual wellness, right? The partners people have and their use of kind of techniques and items that will protect them from STIs, tobacco use, and with that is alcohol and drug use. And then also emergency and safety, right? Do people know how to handle when they've been injured and how to engage with the services involved? And hygiene. We know that even basic hygiene can have an impact, especially if people have chronic conditions. Even basic hygiene can have a significant impact on people's wellness. Okay. So we're going to switch gears. And the next kind of thing is going to be our kind of meat and potatoes around the counseling techniques specific to health and wellness. But wanted to take a minute or two here just to see if people have any questions, comments.
Okay, so no questions, but I think just sort of backing up a little bit to some of the other comments related to what people feel would be a success in a medical harm reduction. Description would be client determining their success for their lives, and also that if the provider themselves feeling successful, if they're helping clients meet their needs related to their medical challenges. And yeah, and then basically success every stage of their lives. Okay. Questions?
Okay.
I just wanted to add though,
Yeah.
what we try to do is introduce ideas around it. Obviously, it's hard to be exhaustive, but I think on a second look of the list with regard to health skills, I think socialization is definitely pretty important as well. And I think, I'm sure Ashley, you agree around how we have noticed a deterioration of some of the overall health of some of the clients that our case managers work with because of the social isolation as a result of the pandemic. So socialization, and I think there's one other, perhaps spiritual health as well.
Yeah, absolutely.
I see a question in the chat from Michelle. Anne, would you like to address that?
Let's see here. Yeah, well, no, go ahead. Actually, I'm going to scroll down.
Sure. It says, how can the stigma of older adults being drug users be addressed?
Right in there with the softball.
The stigma of older adults
being
drug users can be addressed.
Yeah.
Okay.
I think asking the question, right? Because I think exactly that is, so stigma, I suppose, is thinking that like everyone doesn't have this issue, or this issue is something that doesn't exist or exists on a tiny scale. But what we know is that people use drugs regardless of age, right? And I think when I'm often asked about substance use, my next word is almost always trauma. And so if you are seeing an elderly person using substances, my sense is that it's possible that there could have been trauma, just like if you see a child or an adolescent or an adult. And I think being transparent and honest and non-judgmental when we're talking to people about substance use, regardless of age, is how we decrease the subject, asking questions about substance use in a manner that you ask about any other thing, right? How often, and without, because it really is a decision, just like any other decision. How often do you take a shower? How often do you use drugs? Now that's a little flippant, but I think the more we treat it like something that you can't talk about, the more likely it is that people won't talk about it.
Right. And I think that, you know, to follow up on that, first of all, it's a multi-layer question. Then she added, this is populations overlooked in New York City. Yes, I think so. The additional questions that I might ask would be, what are the drugs? How long? Are they homeless? Are they out in the streets? How is it affecting their health overall? And at what point, you know, really the adage of social workers, which is starting where they are, is it even a problem? Do they even see it as an issue? Because if they don't, this is harm reduction, right? I mean, we provide the service and care that they ask for. We try to invite them to consider that perhaps using the alcohol, tobacco, marijuana to excess, or any heavier heroin, any other drugs that are cocaine, crack, I mean, anything that's sort of used to excess could really create health issues. And this is where it's tied in with your overall health. Then we ask the question as to whether this is something that they've considered. Invite them to perhaps make the connection. And some people actually do, like when I was working in an inpatient program and I would scan our population, you can tell who had been abusing alcohol since they were in their 20s, just by their physical health, not to mention their mental health, which is what Ashley was talking about with regard to trauma. So yeah, a lot of ways of trying to address it. I mean, again, not comprehensive in terms of being able to address it and completely solve the issue, but we start always with what questions can we ask so that the person actually begins to engage with us around problem definition and then solution development.
Yeah, and I think that the question asker highlighted something that we see in the community. I think a lot, this is coming from my experience in permanent supportive housing, is that the next level of care, right, from permanent supportive housing or housing with enhanced services tends to be a more nursing environment, assisted living environment. And that environment is often not set up to work with people that are using substances. And so there is an entire population that has needs like a skilled nursing need or you know, some kind of care, 24-hour care, but because folks have, yeah, they're coping with substances or they're self-medicating substances, then they're unable to access a level of care that they truly do need because of this issue. And so maybe if more care providers were more aware of substances and how to work with that population, people could be getting the care that they needed. Yeah, that was just something that popped up. So that's anecdotal. Anecdotal.
And I really welcome all of you sharing total stuff, really. It makes it real, and I think it's amazing how there's so much commonality across a lot of different communities that we serve. I think the issue of the elderly historically abusing pain medications, I mean, we wouldn't have had that opioid crisis we're still dealing with, and which has very negative health ramifications for a lot of people. And aside from causing some pretty major death issue, right? I mean, GI, just addiction, the solution becomes the problem. That we also look at it from the way that systemically, this is how pain is managed, as opposed to alternative pain management practices, such as meditation, you know, alternative medicine. I think, and this is something an area that we can all challenge as providers, that we ask the question of the medical professions, how much opioid is reasonable, how much morphine is reasonable, particularly when you're dealing with hospice care. You know, just a lot of hard questions around reevaluating how we treat elderly who say they're in pain. to be more open about being able to, understand that pain is, first of all, intangible and very subjective. And again, going back to that, perhaps it's trauma that needs to be addressed, and body work, meditation, yoga, lots of so many other things that can be addressed rather than just sort of handing people pills and saying, join the club. Yeah.
Okay, this is making me think, do we want to take like a 2-minute break before we dive into this next part?
Your call.
I do. All right.
Okay, so let's do a break.
Maybe 3 minutes at 10:40. Maybe at 10:40 we'll come back, because I do think this crowd is probably going to have questions about, something tells me that this next part is going to be a discussion part.
Right. Well, if Ashley's taking a break, I would say all should too. But while she's taking a break, go ahead, Ashley. Over the next 3 minutes, begin to form some questions if you like, and you can begin placing those in the Q&A feature, which is there at the bottom of your screen. You can also put them in the chat, but it's just easier for us to retrieve them if they are full-on questions, if they're in the Q&A feature. So thanks. While we take a little bit of a break, I'm also going to place again the information for those who are looking for continuing education units in the chat. I'm going to put that there again just to refresh. And this will be a survey that I require everyone to fill out for continuing education units. Again, there will be 2 surveys for those who need continuing education units. There's going to be a survey that Ashley invites everybody to fill out at the end of the training. But the one that you see in the chat right now is the survey link for those who are looking for continuing education units. So save that link. I'll put it in again at the very end, but that's the one you need to fill out for our CEUs, for RNs, LCSWs, MFTs, and LEPs, LPCCs, and attorneys and fiduciaries. So thanks for paying attention to that. If you have any other questions about continuing education, you may write to me at cmorgan@ioaging.org. That address is there in the chat feature. So thanks for being with us. We'll be getting started back up in just a minute. And in the meantime, if you have any other thoughts or questions, as we said, put the questions in the Q&A feature and we will collect those as we go. And we will be attentive to anything we see in the chat as well. So it was also great to see all of the different organizations folks are here representing today. That's always wonderful. If you've been to IOA's trainings before, and you are still expecting some CEUs from me for a recent past training, hold tight. We have a little bit of a log jam there because there have been a lot of trainings recently, but you'll be getting those soon. And thanks. We'll be waiting for Ashley here for just another minute or so. In a minute, stand up, take a deep breath, and just get ready for the next portion of this training. And she is back. And Ashley, I was just telling everybody that if they need CEUs, they can refer to the chat. I just put that information back in the chat for everybody. And it looks like I'll be monitoring the Q&A chat for a little while. So whenever you'd like to get started again, please feel free.
Okay. Sorry. All right. So MI is motivational interviewing. This is probably a refresher for the social workers in the room, but it's also a counseling technique that I think is now kind of like the gold standard for supporting people around behavior change. And so this is kind of talks about the spirit of motivational interviewing and kind of the 4 major concepts that we want to be thinking about when we're having conversations with people around changing behavior. And this could be changing a positive behavior or trying to like that could be adding a positive behavior like exercising more. It could also be decreasing a negative behavior like drug use or not taking medication that we know can be helpful. So partnership is one of the kind of major core tenets, which is working in collaboration and in partnership with the client. The catchy phrase is you don't motivational interview people, rather you use it with people. So it's not at, it's with. And then acceptance kind of dovetails into autonomy. So, and this comes from the idea that if people are making decisions for their own reasons and for things that are relevant and resonant with them, they're much more likely to start a new behavior and maintain it because it's consistent with things that are important to them. And then the opposite of this would be to make people do things, coerce and control, right? So like people making a decision for someone else. It's been kind of studied. If you're making a decision for someone else, it's hard to maintain motivation. And that's really kind of thinking motivational interviewing is about identifying what are the things that help people stay motivated and generally finding people's personal motivations and personal reasons for making a change and maintaining that change behavior state is the kind of autonomy and the things we really kind of want to empower. And within that acceptance is kind of offering people absolute worth and accurately expressing empathy. And within that, we can provide affirmations and supporting people's autonomy and kind of independence around decision making. And then compassion is giving priority to your client's needs and being aware of what's beneficial to them and being consistently compassionate for the situation that they're in. And then evocation, the resources for change and motivation are presumed to reside within the individual, right? That clients can be the agents of their own change and that they have what they need to make the change inside them already. It's just a process of drawing that out and making it more conscious for them. And this means that we want to put the client in the kind of active speaking role. So they're the ones talking about how to make a change, what changes to make, versus the client being in a passive role where you as a provider are telling them what to do and telling them why they should change. We want it to come from them. And so a lot of what we'll be talking about now will be kind of how to draw out those thoughts and how to draw out that change talk. So the right-hand picture is kind of the stages of change with a clever diagram. So bottom of the stairs is pre-contemplation. Person's chilling out, being like, nah, not me. That's not something I need to do. I don't need to change my behavior. Whatever this is not a problem. Or if it's a problem, it doesn't affect me. You know, this is pre-contemplation. Is a particularly can be a frustrating position as a provider to watch a client be in, because pre-contemplation is very opposed to when a provider sees an issue and a client does not, right? So if the client is living in pre-contemplation, no, not me, not a problem. Not even thinking about pre-contemplation before thought of an issue. Next step, guy sitting on the step, or the person is sitting on the step saying, maybe this is an issue. But just thinking, there's not action in contemplation, just thought. People are thinking about making a change. Perhaps when they're hearing information about the specific problem, they might it might kind of feel like someone could be talking about them. And then there's preparation, which is, okay, maybe I do think this is an issue. What do I do? How do I make a plan? What plan works? What plan do I want? And preparation still is not action. There's not a behavior change happening at this, but there is momentum. And then action. That's the phase a lot of us care providers want our people to be in. We want them to make the change, to make that appointment, to take that medication, to see that therapist. We know the thing. We want them to do the thing. That's action, right? Okay, let's do this. I'm on board. I believe this is a problem. I think it's an issue. I want to make a change. I'm planning to make a change and I am doing it. This is a very, very exciting phase. There's lots of motivation here. And maintenance, which is, it is possible. I have made the change. And now I'm thinking about and doing the change, living in this new situation where I have already made the change. And I believe it's possible to make a change. And this is also a super exciting place to be, where people have made a change and they're starting to reap the benefits or identify that they have successfully moved through this process. One thing that's not on the stair metaphor is relapse, which is a shift back down the stairs to any other stage, right? So if it's working out, you could go from lying on the couch thinking, no, not me, to significant change in your behavior and working all the time. A relapse would be a return to any other stage of change. So you could stop working entirely and go right back down to pre-contemplation, or go back down to preparation, right? So relapse is just a return to a different part of the cycle. And so when we're thinking about how to apply these stages of change, the thing I kind of thought made sense was that each health skill is a behavior. And then if it's a behavior, then people are in a stage of change around it. And so maybe some ways where we could have the clients explain to us what their motivations are, what they're thinking, is to kind of suss out what stage of change they're at with their health skills. And then the kind of practical things when we think about this is, we don't want to be giving advice. And it's hard to do, especially when some things are kind of factual around medical care. And then other thoughts are, how would you want to make this change? How might you go about it in order to be successful? And what about 3 best reasons for doing it? So these are one of many kind of questions that you can think about when you're talking to your client. And then I have another one here. So this is a readiness ruler. You can also use this as a confidence ruler, but we'll start with readiness. So what changes are you considering? How important is it that you make this change? And how confident are you that you're able to make this change? And how ready are you to make this change? And I think this is really getting at the difference between a closed-ended question and an open-ended question, right? Because if we wanted to make this a closed-ended question for the first one, what changes are you considering? A closed question would be like, are you going to make a change? That's yes, no. And it really limits the conversation. But what changes are you considering? That's really evoking. That's really asking of the client, what do they think? What is a different way of being that they're thinking about? And then the ruler is an interesting tool because you can ask, okay, put yourself on this ruler. How ready are you to make this change? 0, not at all. 10 being very likely. And if the client picks 6, okay, we've got information. Why are you at 6? What would it take to get you to 7? Or if the client shifts very wildly, if one day they're a 6 and the week after that they're at a 2, you can talk about what's the difference, right? And the readiness ruler helps you and the client kind of look at the issue together versus like the client just saying, no, I'm not ready to make a change. It's how ready are they? And really creating an opening for more conversation. So that's the readiness ruler. And then now we'll get into kind of the specific skills of motivational interviewing.
Ashley, are
Yeah.
you taking a question at this time?
Sure. Yeah. We got, yeah.
Okay. One person is asking, would you speak to resistance to change and how to roll with resistance?
That's 2 slides from now, but sure. So like I said, this is probably, like I said, this is probably a refresher for a lot of people, but I think motivational interviewing comes from the stages of change, one, but then also the idea of ambivalence. So ambivalence meaning that clients feel 2 things at the exact same time, right? They feel the desire and the need to change, but then also a desire and want or need to not change at the same time. And so these issues often put people in this kind of weighing situation where sometimes change is what they want to do and sometimes staying the same is what they want to do. And I think ambivalence is a part of the human condition. And so when we're encountering resistance, I think it's good to look at, rolling with resistance versus saying client's resistant, I give up. Asking ourselves, okay, what stage of change do I think this client is at? And sorry, I have a hair on me. Okay. What stage of change do I think this client is at versus what stage of change is the client actually at? Sometimes resistance can be just an indicator that perhaps we think the client is in action, but perhaps they're actually in preparation. But yeah, we can get into that more in a second. But I think rolling with resistance is a skill of I think naming that a client is telling you, I'm not maybe where we need to, I'm not at the place that maybe you think I am. And it's an opportunity to reestablish where maybe on the readiness ruler a client is. I don't know if I answered the question, but I do have some more kind of detail about that. So got a couple slides here on the specific skills of motivational interviewing. So expressing empathy, right? And this is all skills around acknowledging ambivalence. And identifying that sometimes our clients will say things around a goal, but their behavior says the opposite, right? So this could be, I want to stop smoking, I have to stop smoking, but they smoke every day. When behavior and words don't line up, that can be an indicator of ambivalence. And that's kind of why this kind of skill set exists. So first, when we think about expressing empathy, acceptance facilitates change, right? So accepting a client where they're at, regardless of where they are at the stages of change. When a client doesn't feel forced to make a change, when they feel like where they're at is okay, that makes it actually much more likely that they're going to consider making a change, right? Versus if they feel like they're being dragged into it or coerced into it, then it can be harder for them to make change that's going to last, because it might not be coming from their own kind of internal motivation. And then when we're expressing empathy, we want to be using reflective listening. So reflective listening is a lot of paraphrasing. The client says, oh, I'm really having a hard time, saying, today's a rough day. That kind of just basic paraphrasing to make sure that you're indicating that a client, that you are listening to what they're saying. And sometimes, especially if our clients are having kind of mental health issues, or if they're intoxicated in some way, that reflective listening can be really good to helping them contain their thoughts. Even if you're just kind of paraphrasing each sentence back to them, that's helping them know that you're listening. And then ambivalence is normal, right? People feel like they want to change, but they're not ready. they want to change, but they actually don't want to change. Parts of them do, parts of them don't. And I think that's a lot of motivational interviewing is just giving voice to each part of your client. Which part does want to change, which part doesn't, because they're both valid. And then another thing is developing discrepancy, right? Is drawing your client's attention to the behaviors that are maybe contributing to them not being healthy. And then their words that seem to say that they want to be, and just offering that up and asking for their opinion. And then this is kind of how we would try and develop the client's language around presenting arguments for change, as opposed to saying the clinician saying you should change because of this. If the client is saying, here are some reasons why I want to change, and we'll get to that in a second. But there are a few kind of evocative questions to try, and I think we covered these in like the last training, but thoughts for this is thinking like, what are some of the good things about the current behavior that you're doing, right? If it's smoking, right? What do you like about smoking, right? And what do you enjoy about it? How is it helpful? What function is it serving in your life? Because behaviors serve functions, and we might as well identify what those are. And then asking on the other side, what are some not so great things about smoking? Other things you can do to kind of help people understand their issue is to kind of look backwards and forwards, right? If you want to look back before they started having this problem, let's say they have a lung issue because they've been smoking. What was your life like before this happened? What was your life like before you started smoking every day? And then maybe look forward. So, okay, if nothing changes, if you keep smoking exactly the same amount that you are every day, what's going to happen 10 years from now? And seeing if that kind of makes them identify if a change sounds good. And another thing you could do is kind of come alongside them, right? Which is, agree with them not changing, at least for the moment, and see what happens. Because I think that sometimes can throw people off. Okay, so here's our rolling with resistance. So whoever asked the question, you're ahead of the game. So when we're rolling with resistance, we really want to avoid arguing in favor of change, right? Essentially, motivational interviewing is trying to be the clinician. Your role is not to kind of have a stake in any outcome, but just to be sitting with the client, looking at this problem and supporting them in their decision to figure out which direction to take it. And then you don't directly oppose a client's resistance. And you can kind of invite a client to consider another option, but you're never telling them or imposing your thoughts or your beliefs in the situation. And yeah, resistance is kind of a signal, right? Like our clients sometimes don't have great skills on setting a boundary or saying no, or saying this is going too fast, right? Sometimes they'll do it in kind of indirect ways, and resistance is, sometimes it can be a client attempting to communicate that this is not working for me right now. And it's just an indicator to kind of take a step back and identify, okay, what are we looking to accomplish here? And then supporting self-efficacy. And this is a hard one for clients, especially that have started to change their behavior and relapsed back into old habits. And maybe they've gone through this time and time again. It's exhausting. It's exhausting for the providers to watch, it's exhausting for the client. But I think the belief in the possibility of change and us holding that hope, right? Like, I know that you've quit smoking 10 times before, but I think you could probably do it. Because if you've done it 10 times before, you've got practice, and you've got those skills. And then I think this is another thing, is that the client, not the clinician, is responsible for choosing a plan. And this is where we see that autonomy and that power and that control. I think way back in the first training or one of these trainings that I did, the clinician, if you imagine like a horse and a buggy, the clinician is definitely not supposed to be the horse. You should not be the one figuring out where you're going and making all the and using all the motivation to kind of carry the client where where you think they should go. The client should be the one identifying which direction things go. And you can be the person kind of sitting back saying, this is where you're headed. There's another option to go down that path. What do you think? And having that kind of back and forth with the client to invite them to kind of weigh in. So there's cats on the next few slides, mostly because I like animals and figured to give you guys something cool to look at. But it's also an acronym. So DARN CAT, D-A-R-N-C-A-T, stands for desire, ability, reasons, need, commitment, actuation, and taking steps. So DARN CAT is the kind of overall memory device for change talk. And so when we're talking to our clients about health, wellness, we want to be thinking about whether or not they're saying these things in these kind of buckets of things people talk about. So the desire, right? So is a client expressing any desire or statements about preference for change? I want to, I would like to, or I wish. Then the ability, right? If the client starts saying things that speak to them thinking that they could do this, them thinking that they have some thought that there's some ability to accomplish this change. I could, I can, I might be able to. And then reasons. So when the client is generating arguments for change, I'd feel better if, or I need to have more energy to play with my kids. And the second one is the need. Statements about feeling obliged to change. I ought to, or have to, or I really should, this kind of obligation talk. These are all things that we want to be encouraging because this is the client moving through contemplation, right? This is contemplation. This is preparation. This might be action. And then commitment is willingness to change. I'm going to, promise to. And then actuation is statements more about willing to. It's like, I'm ready to, or I'm going to start tomorrow. These are all momentum. And these are things that we can really, really affirm and say, hey, you're really talking about making a commitment for change. That's a big deal, right? This is how we can kind of show folks that they can, right? Even just talking about change is a movement in a positive direction. And then taking steps, the T in DARN CAT, is I actually went out and, or this week I started. Then our last CAT slide. So change talk is the client is verbalizing their desire, their ability, their reasons, their need, commitment and or actions taken. Those are really, really big. And then sustaining talk. If the client is talking about ways that they might sustain their behavior. And then self-exploration. They verbalize they're contemplating or exploring issues around change. Right? I think my doctor has a point. I would experience a lot more energy if I lost some weight. And then resistance, something we should also make sure to keep an eye out for, an ear out for. Is it when a client verbalizes that they're not willing or able to make a change? You know, I'm tired of people suggesting I need to change. I'd rather go to my death happy than slender. You know, those are moments where really just leaning back on our reflective listening and saying, you know, you're not ready for change right now, or, you know, today doesn't feel like a day to make that change, and not reacting to that by trying to disagree with where the client is because the client's telling you. All right, last one before we can have a little discussion. Then the last part of the presentation will be moving on to kind of community health resources and safety planning. So here are some things some questions that really help to clarify a client's priorities and fears. Because sometimes these questions, they might generate lots more information that we kind of didn't know. So if our client has, let's say, 3 or 4 medical conditions, which judging by the problem lists I sometimes see on the charts that we see, tends to be the case, right? Like, which condition are you most concerned about? This also helps us know how much the client knows about their own medical care, their own medical decisions. And then what symptoms are you looking to avoid, or what symptoms do you find most problematic, right? Yeah, like a client might have a lot of fatigue and that might really cause them a problem, or it doesn't. And just really drawing out from them what their experience is and what they think about it. And then who or what matters to you. So, people taking care of their medical conditions, this could help us figure out what their internal motivations are, right? People really, if they really want to be able to remain as independent as long as possible, or to be able to stay with their family as long as possible, to be able to, see friends, like what is important? What are the things that when you're having conversations about people's medical care, what can you point them back to say, hey, we had this conversation that this person or this activity really is important. How is what you're doing or what you're not doing playing into that? And then what activities are you unable to do because of your medical conditions? So this helps us kind of see, if you remember the Venn diagram I had from behavioral health issues, medical issues, and daily activities, this helps us get a handle on what the client sees as the impact their medical conditions have on them. And that might also help us identify ways we can empower them, right? Like, you really like gardening, you say that that's something that you really, really enjoy, but if you're not taking good care of, let's say, a breathing issue, it's hard for you to really get out to your garden and do that task. And then what medications are you wanting to take, right? What medications are people taking? Do they even know what medications they're taking or what they're supposed to be taking and why? And then, what side effects are each of these medications causing? Right? Trying to draw out from the client, like, what, my blood pressure medication, I got no problem with that, but this other one gives me this side effect and I really don't like it. And that allows us to then also advocate with our clients' providers, right? Because sometimes providers sometimes like the doctors or nurses don't have time to have these kind of detailed conversations. And we might be able to have a little more time to ask these kind of granular questions and then advocate, like, hey, I think what we're seeing is this client's not super adherent with this medication because of this thing. And we're able to advocate and help the client problem solve. And then also exploring what kind of side effects are most troubling. And then, what kind of activities or functions are you wanting to make sure you keep? And this is by no means an exhaustive list, and I am not a medical professional, so I'm sure there's a whole other list. But this is just what I was thinking, was questions to kind of evoke what is most important for your clients, and then allow us as community health providers to advocate for what our client wants and help our clients figure out which direction feels best for them. So I saw a hand a second ago, and maybe there's chat things happening.
Yeah, there are. Hi, Ashley. We do have a question in the hopper, and I'd like to bring it to you. Somebody wants to know, when is it not a good time to discuss changes? For example, if someone is intoxicated or manic, or is it better or important to still discuss it anyway, even if they're in that condition, and then see where they are next time, see where they're at next time?
Very good question. I think so obviously case by case basis kind of goes without saying, but I think it depends on the client's baseline, right? If you have a client that is intoxicated every time you talk to them, Then if you're waiting for a time where they're not intoxicated, that might actually not be a reasonable plan. But if you have a client that's, say, normally a little intoxicated and is very intoxicated, you might wait until when you think that they really can retain information. And, I think I talked about in one of my earlier ones, you want to be kind of doing an orientation, right? Does the client know person, place, time, situation? And if they're really disoriented, and you're just trying to like make sure that they get home safely, maybe making a decision, maybe talking about change right then in the moment isn't probably worth it. But I think it also depends on how you approach it. But I'd say generally intoxication shouldn't be a reason that you just like don't have a conversation. But if you think that they're intoxicated to the point of like maybe needing a medical intervention or just needing basic needs like food, water, shelter, and then making sure they get safe, maybe not then. But I think if they're intoxicated, that's a good data point for you to follow up, maybe when they're less intoxicated, to say, hey, we were going to talk about this change on this day and we weren't able to because you were really having a rough day. I'm wondering now if you want to have that conversation. And also I wonder, is the client more intoxicated that day because they knew they were going to have a conversation about change? In which case, is that use maybe indicating some resistance? Maybe readiness for change might not be there. But I think, yeah, it really kind of depends on the client's baseline. So I think Manic was also part of it. It depends on how much the client is able to kind of track information. And sometimes you can have a really small conversation about change. And even if it's just like, what are you thinking about this thing? And you can kind of get it, even if you ask kind of the same question each time, you as someone who is not intoxicated can keep track of what the client's answer is. And then you can give the feedback of like, hey, I've been keeping track of the answer to this question when you've been more symptomatic and less symptomatic. And your answer is this and this and this and this and this. What do you make of that? Then you're able to kind of still be having that conversation in a way that's allowing the client really to self-direct the pace.
Ashley, I have a question for you. And I think we've probably all seen this. When two professionals who are serving the same client may have differing opinions about how that client should be addressing certain concerns.
Mm-hmm.
And sometimes you have the client winding up playing the professionals off against each other, almost like mom and dad, or
Mm-hmm.
well, this person over here doesn't think I have a problem. Why do you? And then how do you see professionals resolving that kind of, situation?
Yeah. So I think I'll go back to, I think I said somewhere earlier that behaviors serve functions, right? It's very often that our clients were not taught how to directly meet their needs or ask for what they need in a really effective way. And so they engage in behaviors that meet their needs, but not maybe in the most effective way. So like splitting staff in that way or getting different answers from different people. I see that as can be very frustrating, but also is an attempt to meet a need. And I think that a team approach is always a good thought. And that's why, so many of us kind of work on teams, even teams that are serving one client across like 7 agencies, I think tends to be how it goes. And so having that kind of frequent contact, right? So if that's case conferences, that is a flurry of emails, phone calls, voicemails, just to make sure everyone is sending the same message. And I think also bringing the client in to have those conversations of, hey, we're all on the call right now, and you told this person this thing, and you told this person that thing. We're all trying to support you, but it's a little unclear what exactly the goal is, right? Does that kind of answer it? And am I on base here?
And I don't see Anne, but I will,
Okay,
that sounds like a satisfying answer.
okay.
Wants to piggyback onto that, you can place it in the chat or place it in the Q&A. I don't see any other questions at this time, but folks, please go ahead and put those in the Q&A if you will. And I guess we can roll on, or are we taking a break, Ashley?
I'm fine to continue. And let's see, I
Great.
have about 11 more slides. So I don't anticipate we will need the entire time here.
Okay.
Which is, yeah. Yeah, might as well keep going.
Yeah, we'll go on. I no doubt there will be some more questions coming up too.
Okay. So now this is really talking about making a medical safety plan. So this is very much coming from the perspective of a social worker who has worked in case management roles and in intensive case management roles. But I think this can apply also if you are engaging with your client in another capacity, but just so you know that that's my lens. So first, and this is like safety plan meant to cover our bases so that when we as providers leave work, ideally at 5 o'clock, we can feel like, okay, I have done what I can to prevent this client from having the worst case scenario happen, right? And I think this client has more or less what they need to be able to access support if things get gnarly. So we want to be kind of identifying our major risk, right? Which of the client's medical conditions are the most dangerous and which kind of really scary thing is most likely. And then we want to be protecting against the worst outcome, right? So what stage of change is my client in around this situation, right? Like what medical condition is their kind of scariest and what could happen if it gets really bad? And what does the client think about it? Because, you know, if a client's in total pre-contemplation around managing all of their medical conditions and some of their medical conditions are very extreme, the end worst case scenario is very scary, right? And then we want to be thinking like, is my client aware of or concerned about the consequences of where they're at with managing their medical conditions? And what can I do to avoid the worst case scenario, right? So most of our folks, that's where we think about having the emergency response system, right? The bracelets, making sure that they have a phone, making sure that they have access to the on-site social workers, or they have the number for the front desk or something, making sure that they have a phone that's turned on. Yeah, and ideally they'd have one of those little buttons that they could call to get help if they fall. And then enhancing stability, right? So what can I do to shore up supports that help the client stay stable? And then how do I connect them with what they need if things get worse? So this is kind of the overall safety plan. And this is a very big, busy slide, and I'm going to zoom in a second, but essentially, this is kind of the overall of the last few months of trainings. So we first started with our mental health and substance use. And this is all the San Francisco ecosystem of care. So this is all San Francisco DPH services. So this is not exhaustive, but this is like, if you're going to engage with like getting an ambulance somewhere, you are going to go one of these places. So we started with mental health and substance use, talking about urgent and emergent, and then kind of transition stabilization services, and then recovery, ongoing wellness. And then next we did housing and talking about like where you can go and how you can access care within kind of our housing San Francisco resources. And then today we are in this world, the medical. So our urgent and emergent, and we talked in our very first training of, okay, when do we know that these issues are an urgent emergency thing? And what do we do? And then we talked also in the last training about the inpatient environments and the urgent care clinics that people can access here in San Francisco. And then transition and stabilization. So medical respite is something that exists in San Francisco. It's kind of down in Soma. And so if you're in the hospital, like inpatient, and you need somewhere to go that isn't a skilled nursing facility, medical respite exists kind of like on the third floor of the sobering center. And it's where people can spend a couple or a few weeks getting that kind of medical care before they transition back to wherever they're living. And then there's health, shelter health is like, there are nurses in shelters, and we see there's nurses like DPH nurses in the shelter in place hotels. And then street medicine, that's kind of like the hot team and their medical outreach. And then there's jail health. And then recovery and wellness is kind of ongoing primary care, ongoing care with a specialist. And then rehab and long-term care, that's like your skilled nursing, your assisted living. And then board and care is like this special thing where it's like you have a house and there's staff there during the day to provide kind of supervision, medication support with that. Okay. So this is kind of options for care, and this is in no means exhaustive, but just kind of like a thing to think about when we're working with our folks. So, depending on your client's level of interest and motivation around their health and using and practicing their health skills, you as a provider can identify resources that support them to be at whatever level of care is most appropriate and realistic for their ongoing safety, stability, and quality of life. So I know that at IOA, our kind of mission is to help seniors and people with disabilities live in the most independent environment, or least restrictive environment, for as long as possible. And so a lot of what our amazing IOA staff, but then also all the clinical collaborative agencies work to do is create wraparound options that support a client at what feels like the most appropriate level for them, given what they've got going on. So the home, being independent at home is one. And then being at home with help. So a lot of our folks live kind of in this region where there's their home and they have a case manager. And then some people will live with family. Some people will live in other options, friends, partners. And then as we move up the levels of care, there's kind of an assisted living, and within assisted living, there's different levels of care within that. And then nursing homes, there's like the skilled nursing facility. And then I think there's other nursing homes. And then there's a hospital, and within the hospital, there are other distinctions, inpatient, ICU, that whole thing. And then this is kind of just like thoughts to think about when people are transitioning from the hospital. And this is all thinking about harm reduction. And because I think what we see also is that these transitions, generally leaving the hospital, can be kind of gnarly sometimes. And so this is just, how do we try and make these transitions either to the hospital or from the hospital as seamless as possible, given that there are many, many different agencies and services involved. So things to consider is discharge planning and advocacy, right? So if you have a client that's in the hospital, calling and getting in touch with people early, getting in touch with the social workers, the medical team early on in a hospitalization, so that you're not trying to figure out people's names as people are discharging. And then things to consider also is clients' activities of daily living and their functional capacity, specifically if there's been any changes in their ADLs throughout their hospitalization, because that will influence the care that you as a community provider want to try to be setting up. And then also you want to be thinking about DME, durable medical equipment. If a client's going to discharge from a hospital and they used to be able to transfer in and out of bed and then they can't, there's probably some equipment that could be in place. And then also want to be thinking about safety and supervision, right? If someone has more needs and they'll be at home, who's going to really be helping? Same thing with medication, are they getting meds delivered? And then who's going to help with follow-up appointments, transportation, and escorting people or accompanying them around. And then the right is just resources that can help with these things. IOA, people call the IOA Connect line if you have any questions. IOA has services that provide many of these things. So health at home or support at home and meals. And we've got our PACE program. There's lots of different things at IOA, but also other options are health at home. And the public authority will do on-call services for caregivers that can come into the home. And then IHSS and Homebridge. And then, delay I have in all caps because sometimes advocacy can be just asking if people can get an extra day in the hospital. And generally the answer is no, but it's always helpful to ask just to say, hey, I'm trying to get these services set up and I want the client to come home and have it be as safe as possible. And then drawing upon the person's support network, their family, their friends, and on-site staff. So our resident case managers, shout out to you, because I know that you're often involved in discharges and figuring out how to get people the help that they need. Okay, so these are my last few slides, and they're all pretty much just like a, hey, did you guys know about this thing? Because they can be very helpful. So for folks that know these things, this is kind of the end of the road, but a helpful review, because sometimes people don't know. So IHSS is our kind of big pool of money, a big pool of services that provide in-home supportive services. And it's a large reason a lot of people are able to stay out of a nursing facility. And then on-call is IHSS offered through the public authority. So if you have a client that is being discharged from a hospital without anyone at home, or they don't have an IHSS worker yet, or they don't have an IHSS worker, like if they had one and that person is no longer working for IHSS or something happened, on-call provides that kind of patch services. And then on-call, they also need to have a critical need for personal care. And so generally that's kind of bathing, toileting, eating, but it's always good to advocate for on-call services if you have a client that's in the hospital that is going to come home. And so this is Homebridge. So IOA has support at home that does in-home support for folks, but Homebridge is another agency, and I'm highlighting specifically here the list of services that Homebridge provides, and I'm gonna, the last two slides will be their specialized Homebridge services. I'm not going to read because they're very detailed, but essentially Homebridge offers paramedical services, and these paramedical services really can be that kind of in-between step between someone being at home and someone going to a nursing kind of environment. So I just wanted to put it on everyone's radar that these things exist. And Catlin will be giving these slides out to everybody afterwards. So you don't have to worry about trying to write these things down. But specific information for Homebridge is that they have to be a senior, blind, disabled, or can't remain safely at home. And then they need to be eligible for Medi-Cal and live in San Francisco. And then these are Homebridge's kind of specialized services. So they have hygiene, client transfers, things they can do in collaboration with physical therapy, and then also use of low-risk medical equipment. So like clipping people's nails, helping people transfer in and out of bed, and supporting folks with incontinence. Kind of the big ones that stand out to me. And then these are more Homebridge paramedical services, and these have to be authorized by a physician and approved for service hours. And so like Homebridge has nurse case managers that trains the staff to perform these paramedical tasks. So if you've got clients that have diabetes, they will do blood glucose. If you have clients that have catheters, they can support them with that. And then if you have a client that needs medications administered, you know, those are just a few that can be really helpful. And then last is adult day health centers. So Anne spoke very eloquently about the impact of socialization on people's mental health, medical health. and want to just highlight the PACE programs. And so I know IOA is a PACE program, as does Unlock and Open House. So these PACE are programs of all-inclusive care for the elderly. And there's an exhaustive list on the slide, but really want to give you guys just a reminder to reach out to see if your clients are eligible for these things. They'll pick people up at home, take them there, give them food, and they've got great socialization, and people can get their medical care and their medications there. It's kind of a one-stop shop and is a really, really great resource. And they are reopening now. Okay, so that's the end of my slides. So definitely open. I know we've got another half hour, but we're definitely open to further discussion. So what I'll do is put the evaluation link in the chat for folks, and that's it's the Clinical Collaboratives evaluation, which is separate from Catlin's. But yeah, thank you guys. I just wanted to say how much I appreciate all of you showing up and listening. And I welcome any questions, comments, concerns while I get that link in the chat for you guys.
Well, Ashley, I've collected a couple of questions for you. You pretty much answered this already, but maybe we can give a succinct answer, and Anne could do that too. What does a social worker do exactly, and how can they help? You did answer that basically, but if you were just to give an elevator pitch, so to speak, how would you answer that question?
Oh boy, what does a social worker do? Well, depending on the client, I think if you ask a lot of the clients, the answer is nothing. But we also do
everything.
So I think it depends very much on the role that a social worker occupies, right? A social worker inside a hospital does a lot of different things than a social worker that is a community case manager. But generally, boy, we started and ended with a very complicated question. But a lot of what a social worker does is talk to a client about an issue and identify the resources that they need, connects them to those resources, and helps them stay connected to those resources. And they provide advocacy, right? So like a community social worker will be kind of the center, like air traffic control, right? Identifying all the needs that a client has, medical, mental health, food, and connecting them with all of those providers, and then supporting the client with how to engage with each of those people. Like a social worker is probably often the person that sees the client in their apartment and is like, whoa, you are sick, you got to go to the hospital, and we'll call the ambulance and then call the hospital and talk to them about that. So the social worker is kind of the glue in between clients and a lot of things. But it depends on the role, right? If you're inside a hospital, your role is different.
Mm-hmm. Yeah, I think that case management as a function actually traditionally was part of the overall social work function, which includes advocacy, community organizing, service brokerage, counseling, therapy, and all of those other things that social workers, depending on the specialty that you develop over time. I think there's also psychiatric social work, which is inpatient primarily. And so the responsibilities are comprehensive assessment of social support systems and living conditions, and developing a discharge plan post-hospitalization. I think the other thing that social workers are pretty amazing with, actually, with the ones that we've worked with now over the past few years, is their interface with family and support systems. I think a lot of the specialties, particularly in medicine, tend to be super busy or super focused on the stuff they really need to do in the center, in the clinic, in the hospital. And so it is the social worker who is able to build the network of support, the interfaces with families and significant others, so that in addition to the more formal in-home support and caregiving services that we try to set up, there's also an informal safety net that the social worker is also pretty important role. I think on the front of it, of course, for a lot of the community-based case managers who we work with and consult with as part of the clinical collaborative, also have I think the burden and responsibility that, of being able to provide a comprehensive assessment of what a client needs, so that they engage all the different systems of care, one of which is medicine, of course. But they tend to, the case manager, social workers tend to be the one to have all of the more intensive relationship with the clients and engagement, so that they actually have a pretty comprehensive initial assessment. They do. What else? Service coordination is a big one. Identifying aspects of the client's care that we need to advocate for, or ask for payment, or
I think we're also,
look for
yeah, I think,
housing. It's a pretty broad role in the medicine world, I think.
yeah, I think social workers then can become LCSWs like Ann and myself. And so if you are a social worker with that clinical credential, that means you have been trained to provide, actual therapy, individual, group, the whole thing, and provide really clinical support, which means if you're someone with advanced training in clinical social work, that means you're holding not just information about the resources that a client needs, but when you're conducting a full assessment, you're doing an assessment also based on the client's psychiatric profile. And so then you're able to be the kind of translator with other agencies around how a client's mental health impacts the rest of their care.
Great. We also, I just wanted to recognize in the chat, one person says she volunteers with the Center for Elders Independence, and it's a wonderful resource. We engage with participants in all sorts of activities and creative outlets. So a shout out to that organization, which is also a PACE program.
Yeah, thanks, Jessica, for that. Finally, for speaking of shout outs, we do have social workers who decide that the best way that they can impact care is by running for office. So we have Willie Brown, who was a social worker at the beginning, and Barbara Lee, who also trained as a social worker. And they decided that in their role as social changers, that they would take on a more greater position in changing government by being in government politics, I guess.
And don't forget Art Agnos too.
Oh, that's right. Art
Yeah.
Agnos is also a social worker.
Social worker, yeah.
Yeah. So those of you that are wanting to go into social work, please come.
Do it. Maybe if there's enough social workers, the caseloads can come down.
There you go. Hey, I do have another question here for Ashley and Ann. You had touched on this when you talked about Homebridge, I think, but bowel and bladder care are big issues. And so that, Homebridge obviously offers that special service. Are there other ones that are in your list that you can give a shout out to or anything like that?
Sure. And I don't work for Homebridge, so this is all just from one of our amazing Homebridge consultees actually gave a fantastic presentation on Homebridge, and I stole this from her. So Vivian, if you're listening, you did a great job, and now I'm using this to further educate everybody as I was educated by you. So I think, let's see, we have bowel and bladder care, and then let's see what else is here. Yeah, this is just general bed, sponge bath, incontinence care. And let's see if the paramedical services and let's see, approved wound care, dealing with ostomy irrigation, replacing bags, enemas, suppositories. Yeah, I think my recommendation would be to reach out to Homebridge directly and ask about their paramedical services. And I'm sure they have, yeah, they'll be able to give you a detailed description.
Great.
Robert.
Oh, Ann, you're muted.
I know, I'm trying to unmute and am I now? Okay, yeah.
Yeah, you're
You're
good.
on.
I think that you might have already covered this. But I think that bowel and well, any kind of incontinence, I think we need to make sure that the primary care doctor is well aware of the occurrence and the severity, because fortunately for us, I think in the US, we have advantages of medical technology, so that there are more and more people now who are getting, I mean, Medicare paying, of course, paying for kind of like a pacemaker, so that it controls the bladder a little bit better. And then also the bowel incontinence can be a symptom of something bigger. So often it's really a good idea to make sure that the physician or the medical professionals at this point really do a full comprehensive evaluation, not just the actual physical checkup, but also a lot of the labs of chemistry, the unusual neurologic or endocrinology evaluation of the clients. So yeah, so on the front end, making sure that we all understand the nature and etiology of the bowel and bladder incontinence, and then advocate for the case managers and social workers to advocate for equitable treatment